Education Committee and Quality Improvement and Review Committee. And after she graduates with us, she's heading back to Minneapolis, where she'll be working with Alina with some of our former UW OBGYN graduates. Under the mentorship of Dr. Williams and Dr. Tyler, she has also presented her work on cardiovascular risk counseling for women with the diagnosis of a hypertensive disorder during pregnancy. And this may show up in her talk today on cardiovascular disease and pregnancy. So I'm going to turn it on over to Kathleen. And if you need this code, it again is typed into the chat box of the WebEx meeting. All right, I'm going to turn over the screen to Kathleen here.
Thank you for that introduction, Dr. Antony. I appreciate the opportunity to talk to you all today. I did time this out to be pretty close to just over 40 minutes, so I'm just going to dive right in here. I have no financial disclosures for this talk today. For our learning objectives, our first objective for today will be to review maternal mortality trends in the United States and improve upon our understanding of the impact of acquired cardiovascular disease on maternal health. From there, I will review cardiovascular risk factors in pregnancy and discuss the disparities that affect our patients. Our third objective will be to further our understanding of the risk stratification tools and recommended evaluation for cardiovascular disease that was described by the California Toolkit and the recent ACOG practice bulletin. And finally, I hope to leave you with an understanding of ways we can work to reduce cardiovascular morbidity and mortality in our own community. From a global perspective, more women in the United States die from pregnancy-related complications than any other developed nation. And every year in the United States, 700 to 900 women die from complications of childbirth. Another 50,000 to 60,000 yearly die. And approximately 60% of these deaths are preventable. Unfortunately, since the 1980s, the trend for maternal mortality in the United States has continued to rise. Over the past years, we've seen a shift in the cause of these pregnancy-related deaths, with an increasing numbers of cardiovascular causes, such as cardiomyopathy and cerebrovascular accidents. While hemorrhage and infection still represent a large portion of these cases at 11 to 12%, if you shift your attention to the right side of the graph, if you combine cardiovascular accidents, cardiomyopathy, and other cardiovascular conditions, they account for 33% of all pregnancy-related deaths. And this rising trend is thought to be primarily due to acquired heart disease, which again will be the focus of the talk today. When I talk about acquired heart disease, and most common presentations include heart failure, myocardial infarction, arrhythmia, and aortic dissection. And why are we seeing this trend? Multiple studies have shown that an increasing number of women in the United States are coming into pregnancy at older ages and with chronic health conditions, including hypertension, diabetes, and obesity. The mean age of the first-time mothers increased 1.4 years from 2000 to 2014, from 24.9 to 26.3 years at age of their first delivery. Approximately 9% of the population, which is what you'll see up here, 35 and older, is now having children over the age of 35 years. And at ages 40 years, the risk of pregnancy and death related to cardiovascular disease increases to 30 times that of women less than 20 years old. When you look at trends for obesity, they've also increased with time. Back in 1994, in Wisconsin, for example, the rate of obesity was approximately 14 to 17%. This is in contrast to 2015, where greater than 20% of the population was obese. And prevalence of maternal obesity increases maternal death risk due to cardiac cause, especially if associated with moderate severe obstructive sleep apnea. You see parallel trends with diabetes as well, increasing to 6 to 7% in the Wisconsin population in 2015, based on CDC data. Similarly, hypertensive disorders now affect up to 10% of pregnancies, and in pregnancies complicated by hypertension, the incidence of myocardial infarction is 13-fold higher than healthy pregnancies, and the risk of heart failure is 8-fold higher. In addition to advanced maternal age, obesity, diabetes, sleep apnea, and hypertension, other risk factors for cardiovascular disease in pregnancy include substance abuse and cardiotoxic drugs, such as some chemotherapy agents, strong family history, and non-Hispanic Black race. The presence of one or more of these factors should raise the threshold for suspicion of a patient's risk for heart disease in pregnancy. Multiple studies have shown that chronic diseases associated with cardiovascular disease are more common in African American women and are more likely to be poorly controlled. This study, in particular, published in the Green Journal in 2017, reported that in addition to increased chronic conditions, African American women were more likely to be on Medicaid, had lower frequency prenatal care visits, and sought care later in their pregnancy than other racial or ethnic groups. Since Medicaid only covers mothers up to 2 months past delivery, low-income women with pre-existing conditions may go uncared for until next pregnancy, which leads to missed opportunities to identify cardiovascular disease risk factors before and between pregnancies and puts these women at higher risk. Which leads me to the last risk factor that we discussed in cardiovascular disease, which is race. Considerable racial disparities exist in pregnancy-related deaths. When you examine the maternal morbidity and mortality reports from the CDC from 2007 to 2016, it is obvious that throughout all the years, American Indian, Alaska Native, and Black non-Hispanic women have much higher rates of mortality per live births. And in comparison to white women, Black women are 3 times more likely to die from all pregnancy-related causes. And that is independent of risk factors and persists for Black women despite income or education level. The CDC data published in 2018 also showed that cardiovascular conditions disproportionately affected non-Hispanic Black women, with cardiomyopathy, thromboembolism, and hypertensive disorders of pregnancy contributing to a higher proportion of deaths in Black women over white women. Black women have a 3.4 times higher risk of dying from cardiovascular disease and pregnancy complications than white women, independent of any other variables. And this is particularly true for cardiomyopathy, which on this graph of causes of death for that time period, you see non-Hispanic Black has 13.9% of deaths versus 8% in white women. So what about Wisconsin? Our data mirrors that of the nation. And in Wisconsin, the maternal mortality rate for white women was 4.5 in 100,000 live births. And for Black women, it was 22.5 in 100,000, giving Black women a 4 times higher risk of death. Cardiovascular disease was similarly the #1 cause of death in our population, and this was a change from the 1998 to the 2005 data, which had previously been due to thromboembolic events. This data also reported that chronic medical conditions were associated with 55% of all causes. Majority of those deaths occurred postpartum, and around 20% were considered avoidable. This data comes from this paper by Michael Schell-Pfeffer, apologize if that's not how you pronounce it, and working with collaboratives like a newly formed Wisconsin Perinatal Quality Collaborative to implement improvement strategies to reduce mortality, as has been successfully done in California and other states. So if we look towards California, California is currently the only state showing consistent reductions in maternal mortality. California reduced its mortality rate from 16.9 per 100,000 live births in 2006, which is when their committee was formed, to 7.3 in 2013. This is a comparison with the nation, which you see in the red line, which continues to rise. Their Perinatal Quality Collaborative, the California Maternal Quality Care Collaborative, or CMQCC, began in 2006 and has worked closely with the state's Maternal Mortality Review Committee to develop toolkits to address and improve the disparities seen in their state. One of the areas of improvement identified through their quality improvement review cycle included cardiovascular disease. Reflective of national and Wisconsin data, the California Maternal Mortality Review Committee found that cardiovascular disease was the leading cause of pregnancy-related death in their state, representing 64% of pregnancy-related deaths, or 2.4 deaths per 100,000 live births. Of those cardiovascular deaths, cardiomyopathy was the most common, representing 45%. Most women who died from cardiovascular disease in pregnancy either had undiagnosed or new onset of disease, and the majority of these patients also presented postpartum, with 75% in the first 1 month postpartum. And again, in California, African American women were found to have much a higher rate of mortality. They were also shown to have an increased incidence of peripartum cardiomyopathy compared to white women, and were typically younger, more frequently presented with severe symptoms, and were more likely to be diagnosed postpartum.
Oh, you're such a good girl.
Excuse me. So when they looked at the data as far as if they thought that there was a chance to alter the outcome, you could see here the strong to good, some, and or no chance. For cardiomyopathy and other cardiovascular causes, they found that 1/4 of all the cardiovascular related deaths were deemed preventable if heart disease had been included in the differential diagnosis and treatment had occurred. And while this is somewhat disheartening, it also represents a potential for change. At this point, I wanted to just take a brief detour to lend some patient perspective to the statistics that I've kind of hammered you with thus far. This is the home screen for a media series created by ProPublica called Lost Mothers. It's a series of both news articles and radio journalism aimed to highlight the issues of maternal morbidity and mortality in the United States. And if you haven't looked at it before or have a chance to look at it later, I encourage you to do so. But the following 2 slides are 2 patient perspectives on their symptoms and diagnosis of cardiomyopathy that I found within this ProPublica series, which started back in 2016. And while they give a limited perspective, they also highlight some of the key areas that California's review committee identified for improvement. So after a month after this patient gave birth to her second child, she went at her OB/GYN office complaining of exhaustion and numbness, and she was told to eat 2 beets and to improve low iron count. 2 days later, she was admitted to the ICU, having gone into heart failure, and this is how she described her experience. This patient survived, but since her diagnosis, she has needed a defibrillator and an open heart surgery, and she reported that she felt her diagnosis was delayed, which led to significant suffering. Another woman said, "I almost died 5 months after giving birth due to peripartum cardiomyopathy. We know now that I've been written off since my second child 3 years earlier. Instead of finding the heart failure, I was treated for bronchitis repeatedly, despite having no prior history of bronchitis before. I sought answers from several doctors because I never felt quite right after my second baby, and not only did they miss it, they had me convinced I was just a complainer." When we go back to the California Quality Review, the things that they pulled out as contributing factors for maternal deaths included healthcare related causes such as delayed or inadequate response to warning signs on behalf of the provider, could be attributed to 61% of cases, ineffective or inappropriate treatment, misdiagnosis, or failure to refer or consult. Similarly, patients fail to recognize symptoms in themselves, with 31% of cases attributed to delays in seeking care, 22% to lack of recognition of symptoms, and other factors including the presence of underlying conditions and obesity. This quality improvement study informed the development of the cardiovascular toolkit. This toolkit and its individual resources is available online to all with registration to the site, which is free. And the toolkit includes many different things, including an algorithm guide to stratify initial evaluation of symptomatic or high-risk pregnant or postpartum women, and also can include sections for clinician and facility level resources for caring for women with congenital or acquired cardiovascular disease, including sections on contraceptive counseling, cardiovascular medications in pregnancy, section on breastfeeding. There's also discussion on racial and ethnic disparities, on cardiovascular disease, and information and infographics for patients. In May of 2019, ACOG released a comprehensive guidance on pregnancy and heart disease, and the practice bulletin outlined screening, diagnosis, and management. These guidelines were largely based on the California Toolkit and essentially summarizes their recommendations. You'll see similar authors between the two. The information in the toolkit and the ACOG practice bulletin is extensive, and while all incredibly valuable, we don't have the time or the attention span to review all of it. So instead, I've kind of pulled out key areas of improvement and education for this talk today. The first area of improvement being a delay in diagnosis. So diagnosis of cardiovascular disease in pregnancy can be challenging because of the overlap of cardiovascular symptoms with those of normal pregnancy. In pregnancy, the cardiovascular system undergoes structural and hemodynamic changes in order to sustain a higher volume load. And as obstetric providers, understanding of those changes is essential. When you think of symptoms of heart failure, many of these symptoms come to mind. However, all of the signs and symptoms listed here can be normal in pregnancy. On average, the resting heart rate of a pregnant woman increases approximately 10 beats per minute, and a heart rate of 90 to 100 could be normal for some patients. Lower extremity edema and postural hypotension are common and are symptoms of increased plasma volume in pregnancy, in addition to the uterine compression that occurs on the IVC during the second and third trimester, which of course reduces venous return to the right ventricle. Palpitations can also be seen and are thought to be secondary to hyperdynamic circulation in pregnancy, but these are typically short-lasting, but can have symptoms of shortness of breath or lightheadedness. Given the large degree of overlap, the California Toolkit provided several algorithms and risk stratification tools to help providers appropriately triage patients. And the first is this table. Signs and symptoms are categorized into low, intermediate, and high risk for disease, and associated color coding recommending next steps, the green being go reassurance, the yellow kind of stop non-emergent reevaluation, and red being a hard stop that this patient needs emergent evaluation. If at all unclear, if you add up to 4 in the yellow column, that should prompt further evaluation. But if you look a little bit closer at the green column, some of the things that we talked about as far as palpitations, that should only last a few seconds and should be self-limited. If they have shortness of breath, it should have no interference with their daily living and should have with heavy exertion only. A heart rate of 90 is normal. If you're getting into 90 to 119, look into a little further non-emergently, versus if you look at the hard stops, all things like shortness of breath at rest, orthopnea, associated syncope, heart rate greater than 120, severe range blood pressures. And in medical school, we're taught that the most likely etiology is probably the correct. And in a majority of patients, the symptoms that they mentioned in their prenatal visit, like some shortness of breath at night or a little bit of ankle swelling, is most likely normal. However, one of the central tenets put forth by the CMQCC to improve physician recognition of cardiovascular disease in pregnancy is to maintain a high index of suspicion at all times. And it's important to think of heart disease as a possibility in every patient or postpartum patient we see in order to allow for early diagnosis, appropriate referrals, and reduction in mortality. So if a patient mentions symptoms, it needs to at least be evaluated with a full history and vitals. And this simplified algorithm from the toolkit is intended for use in those patients who present with symptoms. And if you remember anything from this presentation, remember these red flags. So that would be shortness of breath at rest, severe orthopnea where they need greater than or equal to 4 pillows to sleep at night, have a resting heart rate greater than or equal to 120, severe range blood pressure, elevated respiratory rate, or oxygen saturations, which are less than 94. So any one of those should prompt further evaluation plus consultations with MFM or hospitalist cardiology. And when the quality review committee went back to validate this algorithm, if those red flags that we just discussed had been used alone, they would have identified 56 out of these 64 cases, representing 88% of preventable deaths. The proportion of women identified increased to 93% when they restricted comparison to the 60 cases of women who were symptomatic or had sufficient documentation with which to compare the algorithm. Our second area of focus is the standardization of antepartum and postpartum care. And both the ACOG Practice Bulletin and the California Toolkit recommend baby aspirin for those women identified as high risk for cardiovascular disease and pregnancy. Discussion of physical activity, including 30 minutes at least 3 times per week. Weight monitoring in pregnancy with goals in accordance with the IOM guidelines. Prompt treatment of severe hypertension, and patient education on signs and symptoms of cardiovascular disease and when to seek care. Just briefly on the baby aspirin, because I can never remember all of these, this table is in the ACOG Committee Opinion 743, which is appropriately titled Aspirin in Pregnancy. If you look at the high and moderate, if they have any one of high risk factors, they should be given aspirin. And if they have more than one of the moderate, they should, which ends up being a majority of our patient population. ACOG also recommends that all pregnant women be screened using the California Cardiovascular Risk Assessment Toolkit at least once in pregnancy, and all women should undergo screening in the first encounter, either preconception or the first prenatal visit. And for those women who are identified as high risk, they should be rescreened every trimester and postpartum. And this is the algorithm that they intend for use in that setting. This is for women with no red flag symptoms that indicate need for prompt evaluation and women who do not have a known history of cardiovascular disease. This draws off a lot of the same signs and symptoms we saw on that green, yellow, red table, but I think it's a little bit easier to follow and use. So you may choose to refer to this one. Again, it combines the aspects of the physical exam, your risk factors like age, African American, obesity, as well as vital signs, starting with kind of that orange level, greater than 100 beats per minute, resting heart rate, elevated blood pressure, but not severe, and oxygen saturation kind of in the middle zone, as well as the symptoms listed here that we kind of talked about as well, tachypnea, palpitations, dizziness, syncope. So if the patient has greater than or equal to 1 symptom, 1 vital sign, and 1 risk factor, or any combination of those adding to greater than 4, then they need further evaluation. And at a minimum, that should be an EKG and a BNP. If BNP is elevated, you should get an echocardiogram, and then other workup based on what the symptoms are. So a 24 Holter monitor if arrhythmia is suspected, a referral to cardiology for a treadmill echo if they're presenting with atypical chest pain, and consider chest x-ray, CBC, or other blood workup depending on the presenting symptoms. And if anything abnormal, they need consultation with MFM and primary care, and further workup. In the postpartum period, ACOG now recommends a clinic visit in 7 to 10 days for women with any hypertensive disorders in pregnancy, and a visit in 7 to 14 days for women with known cardiovascular disease. Not sure why that's different. It seems like you could make it 1 for both. They also encourage counseling on contraception, Definitely before delivery or hospital discharge, and to reassess at each visit as needed. Counseling and encouragement of breastfeeding is recommended. A little plug for breastfeeding: studies have shown that a 10% reduction in lifetime cardiovascular disease risk if a patient breastfeeds for just 12 to 6 months. And then again, patient education is highlighted with the importance of understanding of their risk factors, as well as signs and symptoms of cardiovascular disease postpartum. And one of the highlights of both of these recommendations is they talk a lot about beyond the typical 6 weeks and the need for continued comprehensive care beyond pregnancy. Both recommend a 3-month postpartum comprehensive cardiovascular disease visit that's specific to that, with either OB, primary care provider, cardiology, or their heart team. For patients with any of these diagnoses, that includes patients with IUGR or placental abruption, sleep apnea, and AMA. In that visit, we should stress recommendations that patients should be fully aware of their diagnoses and the risk factors, such as the risk of future cardiovascular disease if they had preeclampsia or gestational hypertension pregnancy, or the risk of diabetes if they had gestational diabetes. Patients should also be aware of their actual numbers, like their blood pressure, their lipid levels, their blood sugars, and what their respective goals are for those things. They should have directed counseling on weight loss, exercise, diet, tobacco cessation if indicated, as healthy lifestyle changes can reduce future cardiovascular disease risk up to 13%, and patients should have directed counseling if indicated. When compared to women who remain obese, women who lost weight prior to their next pregnancy can lower their risk of preeclampsia from 12 to 20% in future pregnancies. They should also be set up with a PCP for yearly follow-up and be started on statin or aspirin if their cardiovascular risk score is greater than 10. In that visit, they should also have cholesterol and lipid testing and a fasting glucose, or the oral glucose tolerance test if they have gestational diabetes, as well as a urine protein assessment. So if we look at our own institution, how our institution currently performs with these recommendations, I anecdotally would say that we as an institution do quite well with antepartum management, initiating patients on aspirin, monitoring weight, and managing hypertension. But we don't do so well on patient counseling of risk factors and postpartum management. This was shown in my own retrospective chart review project, which some of you may remember me presenting on this March. In that study, we showed that patients with hypertensive disorders of pregnancy, not examining other risk factors for cardiovascular disease, and that we document counseling very few patients about their future risk of cardiovascular disease, and do a poor job in general of referring patients for cardiovascular disease management. One way we could address these deficiencies is to develop an electronic medical record-based alert system for postpartum follow-up. This was also mentioned at Resident Research Day if you happen to be there. But for those who are not, the system is based on the BP Connect protocol developed by Christy Bartles in the UW Rheumatology group. And the proposed system would essentially include an electronic medical record alert at the time of a postpartum visit, which would be prompted by ICD-10 codes, such as those for hypertensive disorders of pregnancy or gestational diabetes, which would then prompt a brief counseling session on risks and an order for referral to primary care cardiology. I believe Dr. Williams is currently working on developing such a system currently. And in regards to education, the toolkit provides multiple infographics for use in practice. Maryville Hospital does have a handout which is provided to patients titled Post-Birth Warning Signs that does include things like difficulty breathing and chest pain as 2 indications to seek care. But this pamphlet is fairly broad and limited, and to my knowledge, it is located primarily in OB triage and is not given to patients at the time of discharge. This is one of the infographics provided by the toolkit and could be included in all postpartum discharge paperwork. There's at least Spanish available. I don't know if there's other languages available. And finally, I wanted to briefly discuss reduction of healthcare provider bias as a means to improve maternal outcomes. This could be in a talk in itself, and I'm afraid my discussion will likely be inadequate. As I previously stated, the CDC pregnancy-related mortality data has shown that in Black women, higher economic status does not resolve or provide protective effect against poor maternal outcomes seen in this population. So if you look at the college graduate or higher in Black women versus white women, Black women with a college degree was 5 times as high as white women with a similar education as far as pregnancy-related mortality. Multiple studies, including the CMQCC study, have shown that Black patients are less likely to receive cardiovascular therapies of proven benefit and have worse outcomes after such procedures. Both ACOG and the California Maternal Quality Care Collaborative reported that increased rates of cardiovascular disease-related complications among women of color are explained in part by racial and ethnic bias in the provision of healthcare and healthcare system processes. Physician and other staff implicit and explicit bias can often result in misdiagnoses or inappropriate treatment, and health system barriers to efficient triage based on symptom severity, language barriers, and differences in cultural humility are other important factors. One way California has approached this problem was mandating an implicit bias training for all healthcare professionals. This bill was actually signed by the California governor in October of 2019. As we kind of talked about this morning, our department in UW OBGYN has had implicit bias training, but this needs to become more universal if we are to have any impact. So one resource I found that could help aid in implementing such training is in one of the AIM bundles. You'll recognize many of these as already being implemented in our hospital, including the maternal early warning signs. But to my knowledge, the racial disparities bundle has not yet been utilized. Some key components of this bundle include staff-wide education on peripartum racial and ethnic disparities and their root causes, as well as staff-wide education on implicit biases. It also includes mechanisms for reporting for patients, that is, reporting of inequitable care and episodes of miscommunication or disrespect, and also develops a disparities dashboard that monitors process and outcome metrics stratified by race and ethnicity with regular dissemination and stratified performance data to staff and leadership. It also includes discharge instructions that talk about danger and warning signs, what to look out for, whom to call, and design materials that meet patients' health literacy, language, and cultural needs. Finally, if we think back to the algorithms for diagnosis and management of cardiovascular disease in pregnancy, I'll remind you that we stress the importance of standardization of care and that all women should be screened and taken seriously. In the context of racial disparity and potential bias, this tenet is particularly important in African American women. And this slide is taken directly from the California toolkit. So in summary, the heart of the matter is that cardiovascular disease accounts for 33% of all maternal deaths, and Black non-Hispanic women are disproportionately affected. We can work as obstetricians and gynecologists and staff can work to improve outcomes through improved recognition of signs and symptoms, standardization of care through the utilization of the California Toolkit Bundle, the AIM Racial Disparity Bundle, and improvement in patient education. Sorry, I didn't realize I wasn't clicking through. Sorry. These are my references. Thank you.
Kathleen, that was fantastic. So clear and comprehensive. And it points to exactly what I mentioned in my talk this morning, which we will be not only talking about a lot in the future, but really taking action. And before I open it up for questions, I just want to say that, we will be having in the next 1 to 2 weeks an opportunity to discuss together our feelings and thoughts regarding the atrocities we're seeing right now nationally with our Black colleagues. And I'm going to cancel something so that we have a full hour to chat via this mechanism. I don't know how that'll work, but I think it'll work based on our experience in the last 8 weeks. So Kathleen, thank you. That was fantastic. And I'll turn it back to Katie. Katie? I think you're on mute, dear.
Oh, okay. Sorry. I'm back on. Can people hear me?
Yep.
All right. That was an excellent talk, Kathleen. Thank you so much. I think if people have questions, perhaps typing them into the box and I can read them out loud. Because I can't actually see everybody on my screen if you do the raise hand thing. So one question to start. Do you think that it would be helpful if, a lot of these deaths are, postpartum, in the 3 to 6 to even up to 12 months after delivery. And these patients aren't necessarily coming to an OB. They're going to, an emergency room or, somewhere else. And we're not necessarily, and the people who are providing care don't necessarily know that the patient is pregnant. Do you think it'd be helpful if there were like an EMR alert or something that would pop up saying patient delivered within the last 3 to 6 months? Obviously that wouldn't help if they go to a different system, but any thoughts on that?
Yeah, I think that would be great. Like you say, there'd probably be limitations in that a lot of our patients come in from just different systems, whether that be delivering from an outside community or like our high-risk preeclamptics that come on from Beloit and deliver preterm. So that might be difficult in that regard, but I do think it's important when we talk about the transition of care from the postpartum period to the 3 months and beyond. It's one thing if we know that there are these recommendations for the 3 months comprehensive cardiovascular visit with a primary care provider, but does the primary care provider know that? So dissemination and information to those other practices is also going to be really important.
Great, excellent. Other questions? I saw Ahmed suggested that the EMR alert be a QI project, so.
I think it may be, but Dr. Williams might be able to speak a little bit more to that.
Dr. Williams, are you on? She's not, she doesn't appear to be on, unless she's a call-in.
She might not be.
Okay. So let's see. From Katie, I'm not sure which Katie, maybe Katie Sempene. Fantastic presentation, couple things. I would be interested in, sorry, yes, that is Katie Sempene. I'd be interested in working with OBQI and others to work on the disparities bundle. I'll communicate with Kathy Kostrivas, and I'd like to systematize aspirin at the new OB visit. Yes, I agree. I think that we're missing a lot of the people who have the multiple risk factors in the moderate category. I think even, I know some of the OB providers have a smart phrase that they use that they blow into the new OB visit where they look over, essentially every item in that list. So, oh, and Cynthia says more FYI on that. So.
It's not a smart phrase for aspirin. It's kind of a whole new OB thing. Yeah.
And Katie Sempeni says, also ripe for work is to systemize postpartum care. Yes, absolutely. And she recommends NPs to assist with that.
Yeah, it would be great if there could be a system and a standard for what is provided as far as information to the patients at discharge. I mean, one way that I suggested that is those handouts so that everyone looks at it, but how many patients actually look at the many different pieces of paper that they're given. But if it's something that someone gives them and talks about before they go, and obviously labor and delivery and postpartum is always very busy. There's a lot of patients to see, but if there's some way that we could get even just a standard paragraph that is discussed with patients.
I know that Wisconsin is working on being an AIM state, and there may be people on the call who know more about that. I do see Katie Gillespie's name on the call. I don't want to put you on the spot, but I mean, this is all work in progress. And Cynthia also.
Yes, looks like Dr. Watler wrote, the state maternal mortality team has now included interpersonal racism, structural racism, and discrimination as discrete upstream factors contributing to maternal deaths. So hopefully statewide recommendations for action will result in the very near future. CDC grant upon this work was received by DHS, primarily authored by Angie Rohan.
I mean, we have time. Maybe Katie or Melody or Cynthia or somebody could, do a little update so people understand where Wisconsin is. I mean, California is absolutely the state that's leading the way, but we have some efforts underway in Wisconsin.
And maybe Melody or Cynthia or Katie can unmute and jump in.
Hi, this is Melody. Others may be able to speak better, but Wisconsin did become an AIM state, and they were all ready to have a big kickoff event that WAPC and WISPIC was sponsoring, and it was to take place right after the COVID shutdown, so it's been delayed.
Eliza Bennett here is recommending universal aspirin. Carol Carl blew in what looks like their smart phrase for recommendations for aspirin. So, on whether or not patients have any of these factors, and if so, it kind of looks like it adds up and determines whether the patient needs aspirin, which might be very useful to use in the notes. So.
This is Cynthia. Can you hear me?
Yep.
Yeah, so there was a cost effectiveness study looking at aspirin, and universal use was cost effective. I don't think that's recommended by the professional associations, but it's probably a lot easier on all of us so we don't miss people who would otherwise qualify. And I'll just reiterate what Melody said, that yeah, Wisconsin is now considered an AIM state. So we'll be implementing statewide these toolkits and bundles that come from the National AIM program, which are primarily, like Kathleen mentioned, adapted or taken from the California toolkits. And then the maternal mortality review team, which looks at every single maternal death that occurs, will be feeding recommendations to the Wisconsin Perinatal Quality Collaborative about which bundles are going to be the most important, or potentially the most effective, depending on the causes of death. And I just recently got involved in the maternal mortality review team, and so I'm really very much a learner. But I was incredibly happy to hear about the inclusion of a lot of the upstream factors that, Kathleen, that you talked about, including racism and discrimination in healthcare services, and how that contributed to the maternal deaths. And so I think there will be recommendations coming out, and looking at what California did, and the governor actually signing an order that all healthcare professionals have to have implicit bias training, I think was a huge step. And I think it's not entirely clear yet what the impact of implicit bias training is on actual provider behaviors or health outcomes, and what is the best way to do that kind of training, what's the most impactful. Also, I think has a lot of study that needs to be done around it, but I'm really happy that you included all of that in your talk. So thanks very much, Kathleen. That was awesome.
Thank you.
Kathleen, that was just a great talk, and I agree with Cynthia, you know, the governor acting to include implicit bias training in California is a wonderful addition. But some other thing in California that we don't have in Wisconsin is that the way the data flows, they have a system where the data is abstracted from hospital discharge records and then systematically reviewed at the state level. That's something that we don't have, kind of that sort of real time, trying to keep it, get the exact data, review it. You know, I know Katie Gillespie or Deb Arenthal could talk a little bit more about this, but there's a lot about getting the data in a timely manner so that the review committee and so that the state agencies can do some level of oversight.
Mm-hmm. It makes sense with the data that you see now is already, you know, 5 years behind.
Yes, exactly. Perhaps Luther wants to unmute and make a comment too. Otherwise, I can read it out loud. He says, Luther says, we need to consider a collaborative medical complications in pregnancy clinic for patients after pregnancy. Wow. We need to focus on identifying and treating at-risk patients, and we also need to focus more in obesity management. Absolutely. Great. And prior to that, Katie Gillespie made a clarification that maternal mortality review is primarily funded by the MCH Title V block grant, and a CDC grant funding is its specific focus is on death involving substance use. So.
Hi, Katie, I'm muted. Are you there?
Oh, okay, great. Thanks.
Yeah, I was going to say there's not a patient that comes to the clinic, comes to that OB floor, or that I think about in postpartum care that I don't think about cardiovascular risk factors. And so that I think that we really need to, it's not just for pregnancy. The #1 cause of death in this country is not cancer, cardiovascular disease. So if we're going to help our patients, we have to focus on helping them get to the right people for cardiovascular risk management.
Absolutely, and that clinic is a great idea. Yeah, we should talk more about what a potential home for such a clinic might look like, you know, or a setting or where to house that, but I think that's a fabulous idea.
I think they have one at the University of South Florida. And I think that there are several OB programs that have been developing postpartum care. We do a very good job of care of patients in pregnancy, and then after pregnancy, they just kind of go their way. So I think that we need to do a better job of tracking down people that need glucose testing and hypertension monitoring and symptom assessment and lipid screening and metabolic syndrome and all that stuff. We need to do a better job postpartum of keeping track of those folks.
Absolutely. Any last comments or questions? All right, otherwise, I think thank you again, Kathleen, for this excellent grand round. And I'll let everyone get on with their day. Thank you so much for joining us.
Thank you, Kathleen.
Thank you all.
Outstanding job, Kathleen.
Thanks,
Oh,
Dr.
Eliza added one more comment. She says, we can't ignore that California Medicaid covers termination of pregnancy, allowing women to make their own decisions with insurance coverage rather than forcing them to continue pregnancy in the face of serious health risks. That is relevant in terms of the mortality difference. All right, bye.